You also alluded to the fact that the injuries in question were extensive in nature. I want to put to you a very short passage from the evidence of Dr. Schwar in the first inquest, on page 183, volume 83, line 10. Mr. Cooper from the family asks Dr. Schwar, do you agree that these are extensive bruises? Of course, he has gone through all the bruises on both sides, front and back. And Dr. Schwar responds, well, in relationship with the whole body, they do not appear so extensive. There is bruising, but whether one describes them as extensive or not is just a matter of opinion. And that causes Mr. Cooper to be rather exasperated. He says, oh, but doctor, please, this man was extensively bruised. Let us get down to brass tacks. Do you have some sympathy for the exasperation of counsel for the family in the first inquest?
Yes, I think it's a frustration because, and well understood, in that where an issue which is a matter of opinion needs to be assessed, it's subjected generally, I would think, as a best practice to peer review. Now, it is my belief that it doesn't need a selection of trauma surgeons, trauma physicians to make this decision, but most doctors would disagree that the total extent of this bruising was indeed severe, as I testified earlier.
Let's move on. Under heading report on page 8, amount of force to be applied, you make an interesting observation about the wounding threshold. Can you explain to the court what you mean by wounding threshold, and why, in your view, it may have very well been more than 27 impacts to the deceased?
Thank you. Wounding threshold is a term that I used in this description to give to specify the minimum amount of force that would be needed to cause an injury. I'll just give you a quick demonstration. If I had to use my knuckles of one hand to slam and to pound my arm, I won't get an injury. Invariably on the palm of my hand, which is thick, which is resistant, which is well padded, I won't get an injury. But if I had to use the same force against the edge of my eyelid, I might just easily tear the edge of the eyelid and cause a massive bruise, which will bulge and cause my eyelid to swell up. So the threshold of injury in the area of the face or eyelids is much lower than the threshold of injury of my palm. But so there's varying thresholds. On the muscular cutaneous surface, that is tight skin over padded muscle, like over the buttock, over the thighs, over the calves, over the shoulders, it's very well padded and it diffuses energy. So it's not constrained to an area causing injury. So the threshold of injury is higher. We know that that multiple impacts below the threshold will not cause injury, visible injury. It's only when it exceeds the threshold that it can cause injury. So there is every possibility, on that basis alone, there's every possibility that to cause these injuries, and including this one on the right hip that I overlooked earlier, and particularly those over the lower limbs, particularly that large one over the right knee and calf, I think are also repetitive injuries. So that's a second point. So on the first point alone, 27 bruises are likely to be the very minimum number of injuries. It's usually, in the cases I've seen, much more than 27, maybe even multiplied by a factor of 2, 3, 4. The second reason would be to actually cause those injuries. I would think it would be repetitive pounding. So multiple injuries, much more than the numbers that we see.
Thank you, Doctor. Now, can we move to part of your report dealing with systemic effects of extensive bruising?
Yeah.
You note in your report that these in themselves will not necessarily cause immediate death.
Yes.
But they will build up in time. Can you elaborate?
Yes. We do know that these are healing injuries, and so clearly we know that the Imam, the deceased, had survived for a while after receiving these injuries, at least the majority of the green-yellow bruises. So we can't fall into the category that we know those that die immediately after extensive soft tissue injury. This is the other category, those that survive for a while. Those that do then survive for a while, they usually die as a result, primarily as a result of damage to the kidneys. They will go into acute kidney failure. And the reason for the damage is that the crushing, that's why it's called the Cush syndrome, by the way, that the crushing of the subcutaneous tissue and muscle caused actual muscle fibers to disintegrate, to degenerate, disintegrate, to come apart. And it's washed away in the circulation. These are muscle fibers, we call them myoglobin fibers. Muscle, strips of muscle, if you could consider it. And these get washed away with the bloodstream and they get filtered in the kidneys. And when that happens, it can plug up the individual kidney tubules. We call them nephric tubules or nephrons. They plug that up, much like after, I like to use this example because we all know about it. When you're cutting vegetables in the kitchen sink, the vegetable fragments clog up the sink and you've got to physically remove it. So you can't do that with the kidneys. The kidneys clogged up with this myoglobin then go into renal failure. The kidney filter as well as the tubule go into renal failure. I have done many cases of this, my Lord, cases with lesser degrees of this bruising and which are shown under the microscope, naked eye and under the microscope, the kidney damage. I can actually see the myoglobin casts in the tubules as it floods the tubules, and I believe this is very likely in this instance.
So, Doctor, this raises some disturbing questions as to whether, in fact, the Imam could have died as a result of renal failure. You mentioned earlier that you were very concerned about the histology report.
Yes.
Because little or nothing was said.
Yes.
It was said in very general terms. So, for example, kidneys, it simply said congestion and nothing else.
Yes.
If there had been a proper histology examination and description of it, the possibility of finding those traces in the kidney, would that have been a possibility for you?
Definitely possible. It would have resolved the query that we had on this, if there was a proper histology.
Am I right in saying that because there wasn't a proper histological examination, you can't exclude
That's correct.
this as a possible cause of death?
That's right. I cannot exclude it.
Let's move on to the degree of pain and intensity Actually, this is evidence you've already given, but I do want to pause on your
Maybe
commentary.
before you proceed to that, just to indicate, Doctor, that these last comments of yours, you are not the first expert that the court hears about or on in this matter, because Dr. Mulefe also arrived almost at the same conclusion, based on a consensus of the histology reports and the possible effects and consequences there. Thank you.
Thank you, my Lord. And actually, that is an important point, my Lord, and for the benefit of those in the gallery, it should be stressed that the two forensic pathologists worked entirely independently. They were not giving each other reports. So, at the time of the making of the reports, they worked independently without.
The one was in Cape Town, the other in Devon. If I understand correctly.
And there was no communication between them.
I see.
That's correct. In fact, I did not know of Dr. Naidu if he's involved in the whole.
Thank you for the information. Dr. Naidu, what moved you to say the following? In paragraph 27, page 9, Dr. Schwer's answers about pain intensity following the bruises and rib fracture were disconcertingly disingenuous, non-committal, and evasive.
Yes. I believe that this lack of concession is most disturbing from a person of his experience and his seniority, Dr. Schwer, because even if he didn't have any clinical experience, and I have clinical experience, I keep getting involved, but even if he didn't have clinical experience, any ordinary doctor, non-specialist, maybe even a general practitioner, on viewing the injuries in naked eye, we don't have that benefit. We are using reconstructions from a written record, my Lord. But even viewing those injuries with the naked eye would have agreed, conceded that this is severe. I think the measurement of the severity is that would that cause serious systemic problems? And the answer is yes, so that it will be severe. So that would make it severe.
Yes. I have to say, Doctor, that us lay people looking at that evidence of Dr. Schwer, the impression we're getting is that he was attempting to minimize the impact of the harm on the Imam.
Yes.
Would that be an unreasonable conclusion to draw in the circumstances?
It's unavoidable to see it that way for any person.
And on that score, if I can draw attention to your paragraph 29 further down that page, you say Dr. Schwer also averred that the immobilization of the chest cage was more in regard to breathing and not walking. This was being economical with reality.
Yes. I particularly feel that was, I beg to differ very strongly about the degree of pain, fracture, and the injuries of the lower chest wall would cause. That would be significant. So it is really difficult to understand why Dr. Schwer did not concede.
Your that evidence is at page 112 of volume 1. Doctor, you went on to raise a question as to why the deceased appeared to complain just of chest pain and not of limb pain.
Yeah.
And we went on to conclude that for various reasons, the overarching complaint would have been about the chest. Can you explain why?
Yes, it's just my view that chest pain from breathing, because breathing cannot be immobilized or seized, is particularly painful and disturbing and inhibiting to normal function. So I am not surprised that the chest pain was the overarching complaint in this case.
You note in your paragraph 32 that Captain Haron has found it necessary to fetch the 4 pills which he described as loxines, and in your view was more likely to be diloxine,
Yes.
an opiate pain medication. Any comment on the fact that here's a police officer, not medically trained, effectively prescribing an opiate pain medication?
Yes. I have had experience in my initial training as a medical student and student intern in knowing that we used to administer diloxine to patients with severe, such as patients with gangrene, patients with amputated limbs in a motor vehicle accident. That was our opiate go-to at that stage. So that's very strong. And if I am not incorrect, at one point in Caldenes's testimony, he said to be given once a day. If I'm not correct.
I think that's correct. We'll double check that.
Yes, and indicates the frequency. You can't, as an opiate, very strong medication, you can't administer more than once or twice a day. So, that being said, the act of going home to his own home, the security branch officer going home to his own pill cupboard to fetch what had been prescribed for him or a member of his family and to administer it to the deceased is a bit out of character for this. And so what I would have expected that a district surgeon should have been called, he's definitely at that stage. A physician should have been called. The patient should actually have been taken to hospital, in my view though. So this is what's disturbing, that a policeman had to go to that action maneuver to get medication, such strong medication. It testifies not only to the severity of the pain, it could also testify to the fact that there was a reluctance to take him to a physician for medical attention.
Yes, it certainly does.
Just before you proceed, Counsel, so if I understand you correctly, on your last comment,
Yes.
the nature of the injuries that you note,
Yes.
and from your experience, the type of pain that it evoked,
Yes.
and the nature of the medical response required,
Yes.
necessitated the hospitalization of the Imam.
Without a doubt. Thank you.
Thank you, Lord.
Perhaps just before we close on this one, remember the indications are you have read the 1970 inquest record, but you recall that the record suggests
Yes.
that the police officers themselves, all of them,
Yes.
when they testified, did not divulge that the Imam was actually taken away from Maitland Police Station from the morning 7:40 or 42, if I recall correctly, the morning of the 17th, and returned on the 19th
Yes.
after 9 in the evening. That he was with the security branch during that period.
Yes.
In other words, that he was not at Maitland police station. He was, according to them, taken out for investigation and further interrogation.
Yeah.
It seems, from my understanding of the record, that the suggestion that it was even out of Cape Town.
Yes.
One, against that background, it seems to me that even the concealing of the report until the probing by Cooper SC, which forced Malan to go, the station commissioner, to go and fetch the records.
Yes.
From which it was then clear that the Imam had not been in the police station. If you take the concealment of that evidence against the background of the failure to call medical attention on this patient, what is your impression?
Yes, Lord, as I went through the record in a sequence,
Yes.
it occurred to me as a dramatic turn in the evidence that was coming through.
Yes.
So it really has struck me as a significant pointer to some sort of attempt to camouflage or to mask the history, I'm not sure of the right word, from the inquest at the beginning, and even when it's even more disturbing when it was disclosed and articulated by Advocate Cooper, it seems not to have affected the assessment of evaluation of these injuries by the presiding officer. So, I mean, but that second part is not something for me as a pathologist to look at. And for me, the most important thing is that the time of origin of the most severe of these injuries, at least all the lower injuries except for those in the chest, are in keeping, at least the green yellow ones, are in keeping with that time sequence, that it was a surge or escalation in injury to the Imam, and a surge in his complaints, in his physical complaints of pain.
Yeah. What I'm trying to get you to comment on is, and whether that impression would be unfair to Dr. Shua. But it seems to me that there was a pattern of behavior calculated to conceal what actually happened to the Imam. And it seems to me that Dr. Shua is not innocent of that whole enterprise of concealing what actually happened to the Imam.
Yes, sir, because I will concur that is a possibility, because I do know of the existence of the problem of what we call dual loyalty amongst physicians, particularly those working in the medical legal fields. Dual loyalty, where you have the loyalty that you should have to the general community and the public versus the loyalty and the loyalties or the relationships that you have with your employer and those you work with. So we know that it's a reality amongst medical legal professionals, and unfortunately it can affect even the best of us.
Nice. Thank you.
As it pleases.
You're welcome to proceed, Council.
Dr. Naidu, we have in fact located the statement of Captain Feldenhuis.
Yes.
And this is Exhibit N of the first inquest, and it's at page 1970 of the record. And in that statement, dealing with complaints made by the deceased on the 20th of September 1969, Captain Feldenhuis says, well, he went back to the office, his office, and he learned that the offices of the district doctors are closed on Saturdays. It seems he's saying, well, the offices are closed, that's the end of the matter, nothing I can do. Am I not correct in saying that typically a district surgeon would be on duty even over weekends and can be called?
Yes, they would be on call. I have consulted with a colleague who has a long history, like me, in clinical forensic practice, and was a district surgeon, and he did indicate to me that there should have been at that stage someone on call
Yes.
at all times.
And indeed, there is evidence before this course that there was a district surgeon on duty and the people.
Yeah, I think Gosling in his testimony indicated that he was on duty that weekend.
Yes,
My recollection.
we'll find that reference for you.
Yes.
He got on further to say that I then went home and took home 4 pain pills, and here's the interesting part, which the district physician had prescribed for my own use on a previous occasion, and gave him to the police station later that afternoon to give to Haron 1 every 4 hours. So here we have his admission. He was only given this by the district surgeon himself
Yes.
on a prescription.
Yes. I agree that he would have known the effectivity of the strength of these medications he would be familiar with, and he would have found it appropriate to prescribe the same for the severe pain disease.
And he is saying not once a day, but once every 4 hours.
Oh, that's it.
So let's then move on. And if we can turn to the heading on page 10, causation of injuries.
Yeah.
And here, Doctor, we're interested in your views as to whether the claims of the security branch that the injuries reflected in the post-mortem report took place during the alleged fall down the staircase. You've come to the conclusion that that version is unlikely. Can you explain to the court how you reached that conclusion?
Yes, thank you. Lord, I have had occasion yesterday, late afternoon, to see the staircase and to look, to ascend and descend over it and assess the dynamics of a falling person on the staircase. And even though I thought that was not immediately essential, I could judge for myself. So I also made note of the breadth of the leading or protruding edge of the handrail, as well as the nature of the edge of the step. It is not actually bullnosed, but it has a slightly curving lip. So each stair is not a narrow edge like this stand, but it is a slightly curving lip, giving you a slight curve. Notwithstanding that, my Lord, I found it not necessary to change any view that I have already compiled within my report. Now, just before I tell you about whether I think it can be related to a fall of the stairs, I noted that there was conflict between the evidence of Sergeant Van Beek and Captain Pienaar about whether there was a light illuminating the staircase at that time. So Captain Pienaar said that it was, Van Beek said that there was a light at the bottom of the stairwell, so he could see the deceased fall, while Captain Pienaar said that the light was all out of order and it was dark in the staircase. Having been there, I think it would be at 9 o'clock at night, and if there was load shedding and there's no lights at all in the entire stairwell, even from above, it would be pretty dark. But I don't know whether there were lights at the higher reaches of the stairwell because it's a spiral. So, now just look at the dynamics of falling down the staircase.
Just maybe to correct, it seems to me that if I understand the record correctly, the person who was there with Van Dyke was a Major Hills.
Yes.
Yeah, not Pilar.
Yes. Although Captain Pienaar in his testimony, did say that there was no lights.
Yes, I noted that, but I'm talking about contemporaneous with the alleged fall.
At that time.
Yes.
Yes.
The two-way Van Dyke and Pierce.
Yes.
You're welcome to proceed.
Thank you, Lord. If a few minutes ago I had occasion to unexpectedly step, and I didn't notice that there was a sudden drop in the plane, and I caught my step with a jar, it jarred me. And for the same reason, I just thought it was expedient to mention that, because when you are falling, or when you are anticipating a fall, either on an uneven roadway in the middle of the night, or where there's ruts and ditches in the road, or an uneven roadway, etc., when there's no light, or walking down the staircase, anticipation and neurophysiological preparedness is everything. So that is why we can survive falls. If we do not have neurophysiological preparedness and anticipation, and particularly when someone is under the influence of alcohol or drugs, or has a neurological disability, you wouldn't be walking anywhere to get to a staircase. Like a person with cerebral palsy, or there are lots of neurological disabilities. They do not have that preparedness, and that's when they fall uncontrollably. And that's the falls that Mr. Woodley was talking about in the research articles I also have, where such falls will cause severe head, spinal, facial injuries and fractures, pelvic and limb fractures. So we're not seeing that. A person who, therefore, in a sound and sober mind, like I believe the Imam must have been, as a sober person, and unless just a bit weak with all the strain, he would have been anticipating the dropping of the staircase. So therefore, Lord, putting in summary, the response to falling, an impending fall, would be both to spring out your hands to grasp any support, and at the same time to drop the height of the body by buckling the feet, the knees, and crouching, so that it reduces the drop force upon any part of the body. For example, persons who are training as dancers or ballet or aerobics or whatever you call it, are taught how to fall, and they're taught that if they are falling, to drop their level of the height in the body by using the leg muscles, the thigh and the calves, and almost like an hydraulic system, to slow down the fall and drop the height so that the injury is reduced. And that the third thing is, besides the flinging of the hands and dropping height, would be to protect the delicate parts of the body. So the delicate parts of the body would be the fragile facial tissues, the cranium itself, because automatically, instinctively we protect the head, not just the face, we protect the neurological portions, and then the delicate parts of the body, such as the abdomen, the genitals. So we want to fall on the buttocks, on the shoulders, on the side, and on the back, and trying to protect the delicate parts, delicate and vital parts. Having said that, one thing is important. In all those 27 injuries, large as they were, none of them would have exhibited have exhibited aberrations, and that's very significant. Now, abrasions, unlike bruises, they fade. Abrasions, you will see a surface scar weeks later, days and weeks later. So it's almost impossible for Dr. Schwer not to have seen abrasions that they were. Therefore, the absence of abrasions is quite inconsistent with falling down the staircase. Falling on the ground or falling on the staircase. Abrasions are the result of frictional impact. There has to be impact, but a little bit of friction. So that is invariable in a fall. And in particular in fall down staircases. I would have expected abrasions, not bruises, abrasions on the shoulders, elbows, sides of the knees, and perhaps the hip, but abrasions, not bruises. The absence of abrasions makes that fall in scenario quite remote.
And Doctor, what about the distribution or pattern of injuries? Because here we are seeing injuries as in bruises,
Yes.
Either external or subcutaneous, the front, the back, and both sides.
Yeah.
How does a fall possibly explain injuries on so many parts?
Yes. Forgive me, I overlooked such a immediately important matter about its circumferential location. It's entirely inconsistent, being present in the front, sides, back, and particularly between the legs, between the lower limbs. Entirely inconsistent with falling on the staircase.
And Doctor, on that score, I want to refer you to some more remarkable testimony from Dr. Schwer, where he seemed to entertain the possibility that such injuries could in fact have occurred during a fall down a staircase. And Lord, I'm referring to page 176 of Dr. Schwer's evidence in volume A3. And Mr. Cooper was asking various questions. He pointed out that there are injuries on his buttocks. He says, to account for them on both sides, in fact, we would have expected him to fall face downwards, not so. And Schwer says, well, it depends if he falls a little onto his one side and then in the fall also onto the other side, this could explain it. And Cooper responds, yes, but how much must he turn to get from his buttocks onto his chest, first to the left and then to the right? What kind of gymnastic feat must he be performing? Schwer says, no, it's not a matter of gymnastic feet. It's a matter of a falling body. And Cooper says, but a falling body which we have described as going down with his back towards the stairs, with his buttocks on the stairs, this is of course the version of the police, not turning or making the degree of turn which you have conceded would or could account for the chest injury. And Schwer says, well, this is what I can say, it depends on the other evidence. I'm not in a position to judge whether it's correct or not. What comment do you have on Dr. Schwer's response that this would have been possible on all different sides, front and back?
It was what I drew, where because of that particular exchange, I drew the closer to the impression that this non-committedness, I'm not sure if that's the word, or evasiveness of Dr. Schwer could not be supported, because I would think that he, or if I would use my own level of experience, to not be able to guide this court or any court about likely possibilities in a more focused way, I would be failing in my duty. And I think physicians who do not do that, unless limited by experience and knowledge, if they do not do that, they are failing in their duty to cause.
Thank you, Doctor. And I just want to put certain measurements.
Just to conclude on that one, if you look at the last question of Mr. Cooper on that page 176, and the answer that
I got the impression that Dr. Shway himself agreed with the proposition that the injuries sustained by the Imam would not all have resulted from it.
Yes, I think he did concede that, Your Worship. It was a concession that he made, but not much more specific than that.
I will take a shot again. Something that needs attention. Thank you.
Yes.
Dr. Naidu, this morning you've already testified to the effect that the amount of force applied to these injuries could be described.
That the body sketches I inspected yesterday, and I believe that they are a very good depiction or recreation of those wounds that I've drawn on my sketches.
Yes. I
went through each one of them. If I may start by showing this particular view. And also this injury, which purports to be over the side of left chest, not on the left arm, it's under the arm. So in other words, it's hidden below the axilla. And this is the particular wound that I believe that Dr. Gosling or Dr. Viviers had described being on the left side in the midline. He talked about mid-axillary on the left side. It is this wound in line with the armpit, and it's shown in uncolored grey-black, very much like the wounds over the front of the chest on either side of the midline. And that's because these apparently were not visible to the naked eye at post-mortem. All wounds that are all grey and black, not the yellow-green, not the red ones, they were not visible at post-mortem. They were only seen on dissection. The midline incision of the post-mortem is done over the front of the chest and the abdomen, and skin flaps removed like opening of a bowel door, and they reflected around, and that's when you see it. That applies to that wound, as well as this particular wound over the lower back. So these wounds were not visible post-mortem until dissection was made into it. I'd like to say further that the next is that the yellow-green bruises, they were all bruises, by the way, and I think this is important to note that none of them were abrasions. All bruises. I'll just reflect on the meaning of that shortly. The bruises, yellow-green, were those that were presumably 7 to 10 days old, But it could be variance, there could be a variance. It could be 5 to 6 days, or it could be 12 days. And they were in the positions recorded. I must make a note of saying at this stage that they were predominantly on the lower limbs, apart from one over the upper limb, that is the outside of the upper left arm, just below the shoulder. Apart from that, the rest of them were mainly on the hip area and the lower limbs. They were strikingly large, and this is what is very important. They were large, and the depiction of size is in scale with this area. So if this is the calf, the inside of the calf, this is about the size of the wound. We're looking at scaled down to the Imam's body size. And one of these, in particular, the one over the rear of the right knee and lower thigh and upper calf, is overwhelmingly large. This is what I would say. This should be considered as very significant in extent. And Advocate Cooper at the original inquest calculated 560 square centimeters. My own calculation came to very close, 573 square centimeters of bruising. That's very important at this stage to make this note that, and we talk about mainly the green-yellow bruising because that was the most significant. If in the literature it's said that any bruising of the body surface greater than 50 square centimeters is moderately severe, then what about 560 square centimeters, which is tenfold greater? Does that itself not make it a severe state of bruising? That's one thing. So 50 square centimeters versus 560. If we say 50 is moderate, 560 is just reasonable, for the reasonable person it's got to be severe. The second thing is that it is said that bruising of about 50 square centimeters being moderate, if neglected and not treated, becomes serious. So what I'm saying is, on the whole, this is a serious state of bruising. And by Dr. Schwer's statement is that there was subcutaneous tissue involvement. In my experience, when I find subcutaneous tissue involvement, I usually find, if I look deeper, that there was muscle damage as well. I see the bruises in the muscle when I do these cases, and I've done many such cases. So it is difficult to understand Dr. Schwer's assertion that this is altogether not serious, and I think it was brought to the attention of the court yesterday that they were not of serious nature. I find it I can't reconcile this. I'm still coming back to the individual bruises, and I appreciate the latitude given to me. The other thing about these bruises, and that's important to make a note of, and I'm going to turn this particular over the back, these bruises are over the areas of the body, unlike the shins over the front, unlike the shins, which is just fairly thin tissue directly over bone, mostly on the shins. In these spaces here, they were all on thick and dense soft tissue. So what it does is, like a force applied onto the shins is stopped by the bone. It's very tender, very painful. You know, if you try hurting yourself on your shins, it's very painful. But it's superficial. This, in fact, in particular, these wounds over the back of the calf, over the back of the Achilles heel, and over the inside of the thigh and the calf, are particularly prone to injure the underlying deep veins, and that is particularly painful. Particularly painful. I need to mention, we come back to the wounds over the chest. Not being visible externally, but Professor or Dr. Schwer at that stage, when he looked inside the chest and looked deep beyond the ribs on the inside of the chest cage, on the left side in particular, he saw the bruising from the left side, on the left side. And what it does, it's a testament to the severity of this. We're not too sure if he saw it on the right side as well. It's an indication of the depth of these.
So in layman's terms, these bruises were visible on the outside as well as the inside of the knee.
Yes. No, you're partially correct, Lord. It apparently wasn't visible on the outside of the skin. Once you lifted the skin layer off, then you saw it.
Yes.
And when you looked on the inside of the chest cage, actually peeking inside,
yes,
you saw it as well.
Yes, that's what I'm referring to. Remember,
yes,
where I am with you now, the skin has been removed.
Yes.
We are looking into the rib cage.
Yes.
All right. It is visible.
Yes.
And then you look in the inside of the rib.
Correct.
It's also visible.
Yes.
And that is why you're saying this demonstrates the severity of.
Yes. Yes. And it's a reflection of depth of infliction and severity.
I see.
The fact that it was not visible externally to the naked eye on the skin may also indicate that they were in a state of more advanced healing than the wounds of the lower limbs. More advanced healing, but they're still visible on the inside. And in one place, one or two places, he talks about a yellow tinge. And that's typically yellow because when blood in a bruise degrades, after a while, it becomes yellow because of hemosidenum.
Just a follow-up question. So the external injuries from the colours, for example, red versus yellow green, as I understand, some very rough estimations
Yes.
on the age of those injuries can be made. The red ones being between 2 to 3 days around then, and the green-yellow a bit longer, between 7 and 10 days.
Yeah.
You mentioned that the injuries discovered on the inside are subcutaneous injuries. Would it be older?
Yes. Those on the front, the lower chest.
Exactly. And also the injury lower down and the injury in the small of the back.
Exactly.
Is there any way of attempting to age those injuries?
It is fraught with difficulty aging. What can be said in wounds in a particular body, what can be said is the relative distances in age between 2 or 3 different wounds. For example, if what I'm suggesting as a possibility is that these were the much earlier wounds. These were fairly recent, but the red ones on the limb, and if you see them on colored red on my diagram, they are fresh, recent, fairly recent as well, even more recent. And that's about, that is our distinction in time. It's about the only, the best and most accurate distinction. You can't be more precise than that for each one.
So it is within the realm of possibility that the subcutaneous injuries could be connected to the complaints the deceased made in July?
Yes, that's correct. So this would not be reconcilable with July. The yellow-green ones would be reconcilable with about, say, 10 days before death. These could well be dated much earlier, even be up to 1.5 to 2 months earlier, these ones. And bear in mind that there was a fractured costochondral, not actually the rib, it was a junction between the rib and cartilage of the right 7th interspace, and I've marked it with an X. So that too, according to Dr. Schwer, he described this having no bleeding, but just a twinge of yellow. So that would also, could well be all related to around the same time.
In fact, Dr. Schwer, question on the fracture, he suggested, and I'll find the exact reference, I'll put it to you a little later, but he suggested that because of the colour, which he described as yellow-green, he then tried to connect the fracture to the incident that had taken place the week before, namely the staircase in the injury. I'll revert to you with the issues.
So, yeah, you?
Which would suggest that there's an inconsistency between what you're saying and what Dr. Schwer said in relation to the fracture.
Oh yes, yes. I think Dr. Schwer's answer there is far too broad. I think what I'm trying to do for the board is to refocus its time sequence. There would be almost to the point of saying there's clear three, that's 1, 2, and 3. These also will be 2. Three incidents in time that it's pointing towards. While we're on this area here of wounding, I'd like to, sorry, I think I was a bit distracted. I was talking about the green-yellow bruises being on the dense subcutaneous tissue, and that it's got significant effects on underlying blood vessels. And not the right thigh front, yes, but in particular the inside of the right thigh, the inside of the right calf, and very much the rear of the right thigh, right knee, and the ankle. Now these are very significant positions because they've got deep soft tissue involvement. They're particularly painful. To the point of being disabling. This injury over the ankle is eminently painful. It will immobilize one, including that. It's immobilizing and it's painful, and I have no doubt, and I'll speak about why I would say that there would be deep muscle involvement in this region. And the reason for that is you only manifest with injury when there is energy imparted to the tissue. And what I'd like to show to my Lord, if I use a force, say I measure a 10 kilogram force against my hand, but because my hand is able to move, so as soon as it strikes, assuming someone else strikes me, the hand moves away, it diffuses the impact. So the actual force of that 10 kilogram hammer striking my hand would be about 1.5 to 2 kilograms, because the rest of it, forgive me, has been diffused. Now, if I had to, the court had to consider how would these injuries have occurred, assuming that someone were to be striking the person and kicking the person, you more than likely would to transfer enough energy and force to cause such a bruise. You would have caused this person to fall. You would have caused him to lose his balance and fall. So it's unrealistic to understand how these wounds can be caused unless if it was with significant force, that's one, significant force and repetitive force to cause these injuries, and more so if there was resistance by the limb to movement away. So what I'm saying is, if I were to be kicking someone to get them to lose balance, almost like a martial arts move, to get them to lose balance, if they're standing, then they would lose balance and fall. I'm saying, Lord, what I'm reading here is these wounds in particular, were caused when there was a resistance to movement against these limbs. For example, if this person was lying prone on the left side and then being struck with the ground, causing the resistance, struck to cause such a wound, that's when such a wound will be caused.
Could that be stamping with a piece of foot?
Such as stamping or tramping or pounding or kicking to cause wounds like this. It's very difficult to quantify it, to measure the amount of force, because we're all different from each other. But what can be said from our experiences and our cases that we've done is this suggests repetitive impacts, one, and very likely being tramped upon or stomped upon whilst on the ground or against the surface. I can't see it being done against a desk or against a wall. I would like to think that this is possible, more likely against the ground. I can't exclude that this more recent reddish bruises, although it's drawn as brown here, the reddish bruises were also similar kind of prodding injuries against the shins. They're particularly painful. You do that. You can conceive the person doing that, trying to get the person to get up, but not cause too much of injury, but get them to get up and walk around. So the wounds that are in red over the shins, the spots of bruises, because they are just a few days old, we must consider that they might have occurred whilst in the Maitland cell, whilst the deceased was lying down flat and directed injury to the shins. I'm not sure if I'm...
Yes. I don't want to interrupt you, but perhaps I should let you finish, because I've got a few questions that arise.
So might I continue?
Please.
You're welcome to continue.
Yeah, thank you, Your Worship.
We must just really try and keep our counsel.
Yes. And we're reliant on my time.
So we have 10 minutes. 20.
Well, we have 20 minutes at least until 12:30.
So I think the important things just focus on fairly quickly, and the principle of resistance against an injury applied also applies here, Your Worship, my Lord, in that to have multiple positions. This is very large as well. Large bruises, multiple positions of bruises over the left chest, or both sides of the chest, where the ribs are pliable at each inspiration and expiration, they're pliable. Suggests that these were significant forces, because when the ribs are so pliable and movable, they transmit forces internally. Same with the abdominal wall, they don't easily injure. So it's a little bit of a greater amount of impact force to cause these wounds. The other thing about it is that they're particularly painful and disabling, because, as you know, you can stop movement by lying down and not move your lower limbs, but you can't stop your breathing. The ventilation all the time, breathing, inspiration, your excursions of your chest continue. And because the chest cage is most mobile in its lower portion rather than the upper portion, therefore bruises and fractures are particularly painful because the chest has to expand. And that's why people submit to abdominal breathing rather than intercostal breathing to avoid pain. Now, it's important to understand that even movement, walking, bending, turning, causes pain. So this itself also inhibits walking and movement. So contrary to what Dr. Schwer was saying, that will remove breathing but not movement. That's what he said. Dr. Schwer said that the chest bruises would limit breathing but not the movement of the body. I beg to differ, because it's the movement that causes your breathing causes you to breathe at a faster rate, the greater ventilatory excursion, much more pain. So you even inhibit yourself from walking. So you try and splint your chest, and that's very difficult to do. I move on, if you allow me.
If I may pause, Doctor, what could potentially have caused that subcutaneous bruising, given their location high on the body?
It's in that location of the body and that kind of distribution and extent. The highest on the list that I must consider is blunt force injuries by either the limbs, it's the fists, by the knuckles, by blows from a fist, or also by an instrument. I'd like to think, I can't exclude an instrument as well, and I'll come back to the instrument when I'm dealing with that and the wound of the back. So I'd like to think that the highest on my list of probabilities would be the hands and the knuckles and the fists.
If the deceased was prostrate at the time, could it have been through kicks?
Yes, you can't exclude kicks as well. If the deceased was adequately clothed with at least a layer or two of garment, you might not see an outside pattern of a heel or the sole of a shoe. not always that you see it. So you can't exclude that. Well, so here, and I'll deal with this wound over the lower abdomen. It was just below the navel, slightly to the left side that I could see it. So it's said to be in the midline, but from Dr. Schwer's very faint diagram, it's placed slightly to the left side. And it's a small wound, about 2.5 centimeters in diameter. And at the same time, and remember that was not seen until the dissection was done. And at the same time, we reflect on that wound. I've positioned it there. It's also slightly to the right side, very slightly to the right side from Dr. Schwer's diagram. Now, in this particular area of the abdominal wall, being a mobile or motile wall, it's a wall that's very flexible. You can, if you're sufficiently skinny like me, you can put your abdomen in, or you can stick your abdomen out. So it's very mobile. Any forces that you apply to the abdominal wall don't typically cause bruises, unlike a bruise on the shoulder where it's firmly resistant. An impact causes a bruise, maybe, abrasion. Over the abdominal wall, it will transfer the force to the internal organs. What happens, it's diffused out into the bowel. That's why you frequently don't sustain injury. Or if you do sustain injury, and it may be on that area, you can rupture the liver or rupture the spleen, or sometimes rupture the bladder, or in the case of a pregnant woman, you can cause injury to the fetus. So it's transmitted forces. It's not very frequent that you get the abdominal wall itself, which is the curtain, to itself bruise. Unless, perhaps, if you're splinting the abdomen and tightening it. But more likely, if the force is such that it's applied by a fairly tapered, pointed structure to that area, so that it tense in or indents the skin to stretch around that focus point and bruise. Therefore, Lord, I'm suggesting that we must consider a focused structure, whether it's a fingertip, it's unlikely, you probably more likely hurt your finger, could be an elbow, less likely a knee to be 2.5 centimeters. I don't think it would be a knee. I'd like to think of some sort of truncheon, and to the extent, thank you for putting up an example of a truncheon. Now that's a police baton or a truncheon. I'd like to think that is a possibility of being used to cause that sort of injury, maybe one or two there, and the bone of the lower back.
And would that be a wound where the head of the truncheon is struck directly?
Struck in the point of
forward motion?
Yes, as a saber type, not saber.
Forward thrust.
A forward thrust, yes, a forward thrust, thank you. Whilst on the truncheon, Lord, on the picture of the truncheon, I'd like to reconcile that with that double linear. Now these are double linear parallel, what we call tramline bruises. Double linear, and the same here on the front of the thigh, and perhaps of the rear of the right thigh. Now, when I say double linear, there's two wounds, they parallel, they typically caused by a single broad truncheon, a rod-shaped, unyielding stick or truncheon, not a thin whip or a rubber, and that would cause, in a single strike, that would cause a double linear. I don't want to go into the details. Why does a single batten or truncheon cause a double linear, a single rod cause a double linear blow? It's just the way the skin indents, and it causes a bleeding on either side of the edge of the truncheon. So I'd like to reconcile that wound over the left thigh laterally, upper front of the right thigh, and over the upper back of the right thigh as being truncheon possibilities. I think I would talk about, I had spoken about pain intensity, and I have no doubt that with all these wounds of the rib area, even the lower limb, any medically trained person, it doesn't have to be forensically trained, it doesn't have to be a torture specialist or assault specialist, it doesn't have to be a trauma surgeon, any medically trained person would reasonably agree that all of these would be considered severe in terms of pain intensity. So this would be, as I mentioned, quite disabling, and would be one of the main reasons, apart from the earlier reason I've spoken about, the prolonged effect on his mental health, being there 4 months, but the injuries would cause the Imam to have been quite immobile. I'm not surprised at all. I'm expecting with these injuries that he would be immobile and static, lying down, not wanting to move, and some probably curled into that fetal position.
And Doctor, just on that score, the significant injury as you described it, on the back of the ankle,
Yes.
the back of the left ankle, around the Achilles tendon.
Yes.
Would you have expected the Imam at that time, following that injury, and as we know that must have taken place a week to 10 minutes before, which puts it in that region of 17 to 19 April, would you have expected the Imam to be limping thereafter?
Oh, definitely, without a doubt. I think he would have been severely disabled from limping. I think that's an important point because the totality of all of these wounds is akin to crush injuries, in particular these ones over the calf. We call it crush injuries, and as I mentioned, if I were to be examining these at postmortem, I would dissect into them and take samples as well. I would find deep muscular bruising, and these are very severe. So not only would they be severely disabling, but they would be serious in terms of the systemic effects, which I will talk about now. But just to finish upon that, I can't see how this would have been caused on the back of the Achilles tendon. These are all crush injuries. I can only consider it's not a ligature type of restraint. It's not like his ankle was caught in a trap or anchored. I can only consider the most high probability is repetitive impacts of a kind of stomping or grinding or kicking or grinding type or tramping type of injury to cause this kind of injury to the deceased.
Could it have potentially been caused by an instrument, such as struck by a truncheon or something similar?
It could be caused by a truncheon, but my feeling is it would be two conditions to satisfy. It's going to be significant injury, because that's a very strong area of the Achilles tendon. And secondly, it might have been repetitive. Most of these injuries possibly being repetitive in nature.
So, Doctor, does that include your description of the wounds?
Yes, that's correct. I believe I have covered most of what I'd like to describe on the wounds, and I just wanted to conclude by talking about, unless I have to come back to that, about the systemic effects.
The systemic effects, I think we will deal with after lunch.
Sure.
Perhaps in the few minutes remaining, you started your description by noticing the total absence of abrasions.
Yes.
And I see also cuts other than wounds.
Yes.
And so I wanted to probe with you, in your experience, having carried out thousands of autopsies,
Yeah.
including autopsies, of course, of individuals who have been abused in police custody. In your experience, did you notice a trend or pattern of the police avoiding that kind of injury, avoiding injuries in which blood would flow, and also avoiding injuries to exposed parts such as the face?
Yes, in particular, in the cases that I've done that did involve the asphyxiation, that's a totally separate experience or situation. Most injuries are caused, in particular, at the low back, which is difficult to detect injuries at the low back area, and over the trunk and the limbs. The trunk and the limbs, not so as not to be manifest on immediate, quick looking at a person in a shirt and full sleeve clothing. You would see it. It's quite a noticeable thing that they would avoid the visible areas for injury.
Dealing with the 12 bruises, you mentioned a medical term that I want you to clarify. And in your paragraph 17a, you mentioned that Dr. Schwar's observation that the bruises involved the subcutaneous tissue, the impact would have transmitted its forces to deep subcutaneous tissue and underlying blood vessels, likely with endothelial injury, in brackets relating venous thrombosis. Can you just elaborate what you mean by endothelial injury?
Yes.
And how that's connected to venous thrombosis?
Yes, I'll try to make this as simple as possible, just to explain the venous thrombosis. 3 conditions need to be met. We call it Virchow's triad. It's actually the original description by Virchow. First of all, that there must be endothelial injury. Endothelial injury is the lining. The endothelium is the lining of the inside of the blood vessel. So if you look at the inside of a water pipe, it's lining inside. Very, very important structure to the integrity of the blood vessel. So if there's injury, platelets tends to stick and start off the clotting process. The second condition is venous stasis. Venous stasis, that means there must be sluggish flow. For example, being supine and bedridden to an extent. Or even not as bad as that, even people who are not hydrated and sitting in long haul flights, we know can get venous thrombosis in the legs, especially if they have a tendency towards it. The third thing is increased coagulability. In other words, the blood becomes a little thicker, a little bit more stickier. And that occurs as a result of trauma. One of the results of trauma is that the greater stickiness of blood. So once those three are satisfied, you've satisfied the conditions, it's ripe now for the thrombosis to occur. Now the endothelial injury, in particular, I could show this, that and that sort of repeated impact will damage the inner lining of the blood vessels, of the delicate veins. Not so much the arteries, because the arteries are stronger, but the delicate veins of the calves, they get damaged. You're satisfying one criteria, immobilization, the second criteria, and the increased stickiness or thickness, viscosity of blood after injury. It's a systemic manifestation. Contributed to that would be the dehydration of the deceased.
Doctor, we have to break for lunch, literally within the next 2 minutes. The last question I want you to deal with, as concisely as quickly as possible, is the attempt during the first inquest by the state to connect the fractured rib with the so-called staircases that was approximately a week to 8 days before. Lord, I refer your report to page 157 of volume A3. I'll just quickly read the extract, Doctor. The prosecutor says, can you come to any conclusion as to when that rib was broken? Schwartz says, in that area there was no fresh bleeding present, from which I concluded that the rib could have been broken, that this rib fracture was already a couple of days, possibly a week old. There was a yellow-brown bruising of the subcutaneous tissue in this area, which is then in accordance with this statement. So the state happily relied on the evidence of Dr. Schwartz to say, well, it probably was from the so-called staircase incident.
Thank you. I think that's very pertinent, because I differ strikingly. First of all, he said he didn't see hemorrhage, and therefore it was, sorry, I'm just wondering if I've got, I must get that correct. He didn't see hemorrhage, but he saw a yellow-brown tinge.
He said there was no fresh bleeding present. From that he concluded the rib could have been broken. The rib fracture was already a couple of days, possibly a week old.
What I'd like to just point out two things. First of all, if you're seeing no bruising, it's much more than a week. At a week, if you open up into a fractured rib, you are likely going to still see the bruising.
His next line is there was yellow-brown bruising in the subcutaneous tissue in this area,
yes,
which is then in accordance with.
That's correct. That's correct. So, if it's yellow-brown and it's at the area of the fractured rib, that yellow-brown tinge will persist for weeks and sometimes for months after an injury, after a fracture. So it is well possible that, well, it was more likely that this fractured rib or costochondral junction was much older than Dr. Schwer is indicating.
So we would be on safe grounds in submitting that Dr. Schwer erred in that conclusion.
Exactly. In fact, I would go so far as saying I wouldn't reconcile that description with that fall down the staircase 8 days earlier. Is it right? 8 days? 8 or 9 days? I would not be able to associate that with that. I don't think I can link it with that date. That would be much earlier, maybe weeks or even up to a month or two earlier.
Thank you, Doctor. Your Lordship, it's just around 12:30. This will be the appropriate time for the adjournment. I propose that Your Lordship is that likelihood of the injuries in the post-mortem report being caused by the alleged staircase fall I want to put to you certain measurements that the aeronautical engineer testified on Tuesday, Mr. Mudley. He brought to the attention of the court the following. When a person falls, and the Imam in particular, given his height and weight, according to Mr. Mudley, he was falling at approximately 3.7 meters a second. And in fact, the entire duration of the alleged fall took place in a fraction of a second. We estimated it to be around 500 milliseconds. In addition, Mr. Moodley said that given that the police claimed he fell from the corner and the step just below the landing, and then he stopped 2 or 3 steps before the bottom of the staircase. On one version, he would have landed with his buttocks on the 5th stair and his feet on either the 2nd or 3rd last stair, in which case, according to Mr. Moodley, he would only have travelled the distance down the stairs of about a metre, just over a metre. And if he'd gone a bit further, perhaps landed with his buttocks on the 2nd or 3rd step from the bottom, then he would have only have travelled about 1.6 metres. When you hear these really small numbers, and you look at the alleged injuries all over the body, both sides, front and back, even to a layperson, one would think, well, on the version of the police, what on earth happened in that 500 milliseconds over a distance of just over a metre? There's not even a sense of disbelief.
Indeed, it just cannot be reconciled. That the spectrum, the distribution, the pattern, the shapes, the sizes, the extent cannot be reconciled with the fall. But with a fall down the staircase. But use the 2 scenarios, the one scenario of falling on the buttocks in that way. What I'd like to say is that it's not really certain as to whether he fell centrally. Let's assume that that particular fall did occur, whether he fell centrally in the middle of the buttock or to one side, because when people fall on the buttock centrally, what they do is they fracture the tip of the coccyx, that is a tailbone, and that's extremely painful as well. They fracture the tailbone, and those kind of people won't be able to sit. They will have to be sitting on a cushion with a hole in the middle because any pressure causes pain. So that clearly hadn't been an occurrence, or we would have seen something suggested in the evidence, in the record, in the observations of the Imam. The other thing is, and maybe I should just mention this, let's assume the security police were arguing that most of these injuries had occurred in that one fall. I cannot see that the deceased would have been getting up, trying to attempt to get up on his own feet, as described by Major Genus. He helped him up. He was already starting to get up, but he helped him up. With these injuries like this, he would have been quite incapacitated immediately, stunned. It would have taken him some time to have recovered before he might have made an attempt to get up on his feet. I think that's important. As I try and do is just relate dynamics of situations to the injury that's caused. So that idea of getting up as soon as he fell and being lifted up on his feet, this doesn't reconcile with itself at all.
Thank you, Doctor. Doctor, you have set out the heading of the likely cause of the injuries, some detail, but we, I believe, have already covered this aspect of your evidence. And unless there's anything further you would like to highlight, I think we can now move to the cardiovascular and pulmonary findings that you set out on page 14.
Yes, I think we have covered most of it.
All right. Well, if there's anything that you wish to highlight further, feel free to bring it to our attention. Turning to the cardiovascular and pulmonary findings, you said that there are three pertinent questions to deal with. One, how significant was the coronary artery disease? What was the contribution of the pulmonary emboli to the death? And what was the relationship of the above to the causes of death?
Yes.
And then you note the sole pathological cardiac finding was the narrowing of the circumflex coronary artery. Since we are a little bit short on time, can you summarize
Yes.
your view on those findings?
Yes, thank you. In terms of the first question, the significance of the coronary artery disease, we really do not know. It's inconclusive. The circumflex is a branch of the main left coronary. So you've got a right, you've got a left, and you've got a branch of the major of the left coronary. So we don't know about the conditions of the two main vessels, the two most significant vessels, which is the main trunk of the left anterior descending, and the right coronary artery and its branches. So it's a sole pathologic finding was this narrowing. Then we also don't know whether it was narrowed down to 2/3 of its existing lumen, that means it's only a 25% drop, or it's narrowed down to 75%, leaving a 25% opening. So even that is not clear.
And just on that score, I was struck by something you said at our consultation yesterday when dealing with whether the narrowing was 75% or 25%.
Yes.
You mentioned the word that was a thumbsuck. What do you mean by that?
Yes, because pathologists generally like this when they don't take a section and look at it under the microscope, when you can measure the amount of constriction. It's a thumbs up look at the nature of constriction, maybe at 50% or 70% or 30% narrowing. We know that's fraught with inaccuracy, the Lord, because if there are a room for the pathologists, we'll all have a quick glance at the coronary and all come to different conclusions. One would say 35%, the other one would say 85%, and one would say 50%. So really, a thumbs up 75% or 3/4 narrowing is not good enough to balance a decision.
And yet it appears that the first inquest placed much reliance on this thumbsuck.
Exactly. So we don't really know how severe this coronary artery disease was. The second point about it, if I might say, is that Dr. Schwer, at the time of the postmortem, and at the time of and even after he did his histology, and when he testified, didn't really indicate to me, at least in my reading, that he had a confident diagnosis. It was always insecure, uncertain. If there was a confident diagnosis of 75% narrowing, and there was evidence my Lord, on the heart, either previous scarring or fibrosis from previous ischemia, previous heart attack, or under the microscope hyperacute changes, then he would have made a confident finding of this is coronary artery, related to coronary artery disease. And he hasn't done that. Just waiting for his lordship to finish writing. The third thing is that, being aware of the time, is that how significant was, or the next thing is, how significant was a pulmonary embolism? From Dr. Schwer's own testimony, it's not significant. You only get sudden deaths, precipitous deaths, when it's either a single large clot that completely occludes the pulmonary artery, so you're shutting off the circulation, or you have a cluster of fine emboli that come up as a bunch and they block the major artery. That's the only time you get immediate death from pulmonary embolism. These are small pulmonary emboli to the extent that Dr. Schwer had to resort to histology to confirm it. Presumably he confirmed it, because we know how shoddy the histology report was. Forgive me for my use of words, it's a shoddy report. So even that is insecure. But so what I'm saying is that the pulmonary emboli, that means the little clots in the venous circulation in the lungs, probably had little contribution, if any, to the cause. So what we're left with, my Lord, is that we've got possibly some coronary artery disease, possibly, almost certainly some coronary artery disease, but the extent of which we don't. From Dr. Schwer's own point of view, is not really secure about that, because it still seems to have to rely upon the pulmonary embolism and rely upon emotional tension to be factors in causing the death from his testimony. So what we really have to depend upon in this court case, and you allow me to say this, is that the only solid, unquestionable, indisputable evidence that is visual in this case, or made visual, and from the testimony, is the wounds. Over 560 square centimeters of the body, severe bruises. This is the primary contributor, primary and main route to the death, against the background of coronary artery disease. So the main factor would be the wounding, with or without the coronary artery disease being a contributory pre-existing situation. I'm not sure if I'm clear.
I follow you.
Okay. I just thought I'll highlight one more. I did say that the death in sleep, because the Imam was in a resting sleeping state when he was found dead. If so, the death in sleep is quite unlike coronary artery disease, unless complicated, where the narrowed cholesterol plaque suddenly gets larger because of bleeding. We call it bleeding in a plaque. Or we got what we call a dissecting aneurysm, or whether we got a coronary thrombosis. Apparently, Lordship was questioning that issue yesterday. None of those three, coronary thrombosis, dissecting aneurysm of the fine artery, or a hemorrhage into a plaque, bleeding into a plaque, none of those were seen either at gross postmortem or at histology. Now, so what we have is uncomplicated coronary artery disease. Then there has to be another factor to cause death, and that is increased demand. In other words, if we say that the coronary artery caused death in this context, there must be something that will be accelerating the heart rate so that it exceeds the demand and the patient dies of ischemia, myocardial ischemia. And that is not occurring in a resting state. It occurs, for example, with a person with a coronary artery disease state running the Cape Marathon, August race or whatever. That sort of physical exertion or states of great emotional tension, but where the heart rate is very high and the demand exceeds the supply through the narrow coronary artery. And that, Lord, is not, you can't consider it, reconcile it with it operating in a resting state. And therefore, I believe that the coronary artery disease may be there, but the prominent factor, most likely cause of death, undoubtedly, in my view, was the consequences of the injury.
So, at the bottom of page 16 of your report, Dr. Naidu, you attempt summing up in your opinion of cause of death, and perhaps you should read your paragraph 63 into the record.
Thank you, Lord. I read paragraph 63, where I conclude, in my opinion, the death was due to a combination of severe systemic physiological stresses, in particular of the crush injury syndrome precipitated by the complications of blunt soft tissue injury with pre-existing coronary artery disease.
And Doctor, to cut to the chase, when you talk about physiological stresses, in particular the crush injury syndrome, precipitated by the complications of blunt and soft tissue injury, since you have excluded the possibility of the alleged staircase for causing these injuries, if we were to cut to the chase, it was ultimately the torture that led directly to the death of Imam Haron.
Well, I would think, in my answer, I would think that these injuries can only be attributable to the source.
But I just want to inform you about certain evidence that emerged in the first inquest. When the body was taken to the mortuary, prior to it being moved to the laboratory, it was noticed that the body was not covered. In fact, it was lying underneath two other bodies. What do you have to say about the treatment of the body of the Imam in that fashion?
I would say simply that this would have been outrageous, an outrageous act. It should never have been allowed to happen. I have campaigned vociferously in my own province and region for this never to happen. I've seen it happen. And in spite of all my exposure, I find it devastatingly damaging to the way we should be treating the dead. That being said, from an ethical viewpoint, there are major implications for loss of forensic evidence, for contamination and transference. If this was a rape case, or this was, for that matter, any case where, such as an assault, where DNA evidence in particular, or biochemical evidence in a child abuse case or in a sudden and unexpected death in a child, I would consider it an outrageous betrayal of even the forensic process and injustice.
So not only did they treat the Imam in death with contempt, but they had little regard for the subsequent examination in order to uncover what happened.
Yes.
Would suggest, Doctor, if you would agree, that they had little regard for the truth.
See, I'll have to concur with that as a possibility.
Doctor, at page 17 of your report, you deal in some detail with the conduct of Dr. Schwer. And because we have already explored this earlier in your evidence, I'm not going to take you through it again. But I do wish to draw your attention to a book. Dr. Malefe, who testified earlier this week, drew this to our attention.
Yes.
And you're probably aware of this book, published, I believe, in the 1980s by Shra and Moksha and Olafila.
Yes.
It's titled The Forensic ABC in Medical Practice, A Practical Guide. It was handed up as Exhibit F3. Indeed, just a chapter dealing with deaths in detention. That's chapter 3. It's titled Miscellaneous Touch Clinical Examinations and Other Responsibilities, and he handed you a copy. And under the heading, Those Under Arrest or in Custody, Dr. Schwer and his colleagues attempt to set out, I suppose, best practice or minimum standards.
Yes.
And then further down on page 259, there's a heading called Death in Detention.
Yes.
And then ultimately, there's a heading called Post-Mortem Examination.
Yes.
He says as follows: the post-mortem examination of the detainee differs from other medical legal post-mortem examinations in that at the subsequent inquest, more importance is attached to certain observations than is generally the case. It is thus essential that special attention be paid to the following. And as Dr. Malefe suggested, and we concur fully with her, Dr. Schwer should be tested against his own standards that he has set out here. And I wish to put them to you and to seek your response as to whether, in your view, Dr. Schwer, in conducting this particular post-mortem examination, met the standards that he laid down, which he expects others to follow. So let's start with the first one. An examination of the body in loco, noting special features and also the immediate environment. To the best of your knowledge, did Dr. Schwer ever carry out an examination in loco in this case?
Not in this case, although he may not have been called. So we are at the mercy of the police, if I may say. If they don't call, then we're not in the know. So, but he didn't do a call, a scene of death examination.
Yes. Obviously, we have to accept that he was only notified after the body had been removed from the cell, and that's beyond his control. Because there's no evidence as to when exactly he was contacted, but it is accepted that no inspection, no examination of loco took place. Secondly, determination of the death interval.
Well, that determination of death interval would have gone hand in hand with the in loco inspection. The observations in the in loco inspection that would impact or feed in to the time of death examination.
And again, we don't know where he was notified.
Yes.
Let's then turn to the next one. A complete and meticulous post-mortem examination. Did he meet that standard?
No. I would call his examination quality level as reasonably, fairly satisfactory, but definitely failing in several respects. So I believe if we were to judge against what we would expect, deaths in detention, this is not the standard. It would have failed that standard.
Dr. Mulefe went so far as to, if I followed his testimony and your testimony correct, there are two possible paths of travel to the death of the Imam. And the one being which we have elaborated, the injuries coupled with the pre-existing heart condition. But Dr. Mulefe also referred to another part, which you also touched on, where the injuries would then affect the kidneys and another path of travel towards death. And just like you, Dr. Mulefe decried the failure to examine and follow the second path of travel.
Yes.
And she, in her words, said that amounts to negligence on the part of Dr. Shaw.
Well, I would concur with that, my Lord. Yes.
I see. You're welcome to proceed. You wanted to say something?
No, I think that covered that.
Thank you.
Doctor, if I may be a little bold and blunt, given that you say that in respect of deaths in detention, that one requires special attention, you say he didn't meet that standard, would we be justified in describing this post-mortem as, in these circumstances, substandard?
Yes, I agree.
Next, determination of the nature and age of the injuries found.
Yes, Lord, this will inform the special investigations, or sorry, say the special investigations would inform the age of the injuries. Now, I have difficulty because the histology report was so inadequate. It does not really amount to a contributory special investigation. And therefore, I believe that standard has not been met. It should have been an essential function. It's also this particular issue about the determination of nature and age of the injuries is also reflected in the testimony of Dr. Schwed, in that he was unwilling to concede seriousness and its relationship to the possibility of assault versus fall on the staircase. Those answers are clear even to the trainee in forensic medicine, if I may say. Those are clear answers. So that standard has not been met in the inadequacy of the special investigation, and even though his reporting was reasonably satisfactory in the testimony that he gave relating to nature and age of the examination.
And then the next standard, which I think you partially answered already, the collection of suitable and adequate specimens for special laboratory examination, in brackets, blood, alcohol, or drugs, histological changes.
Yeah, clearly they fell short of that, although toxicological specimens were taken, and I'm informed that there was no evidence of toxicological substances, but we don't know really what it was actually tested for, but the main thing was the histological examination, principally.
The next one, photo documentation.
I think this is probably my biggest bugbear in this law, in that a number, probably all of the questions, or most of the questions relating to the death of the Imam would have been answered, or would have been clear and apparent, not requiring someone to testify if photo documentation was done. It's such a basic requirement. Today we will do it on almost, we should do it on almost every cause of the 15 to 20,000 unnatural deaths, maybe 15,000 unnatural deaths per year in the country. We could do it in all of them because we've got digital capacity. But even if solely reserved for special high-profile cases, murders and robberies, use of photo documentation in detention cases, in detainees' deaths, and in particular political detainees, is such a shortcoming that I can hardly overstress.
And would it have been within the power and authority of Dr. Schwer to call for a police photographer
Indeed.
to be present and to take those photographs, indeed to insist upon it?
Yes. Indeed, it is at the behest of the pathologist that the photographer is also there. The investigating officer can call for it, and in this case we don't know if there was one, but it's also at the responsibility of the pathologist, and he's got the authority to call for it as well.
Indeed, am I correct in saying that the pathologist should have directed the photographer and told the photographer which parts of the body to photograph?
Correct.
Then lastly, preservation of tissue, e.g. the brain in the case of head injury.
Well, that won't apply because there was no head injury or no apparent head injury.
Or preservation of tissue more generally.
Yes, well, that will point towards refer to the histology.
Yes,
Yeah.
So, all in all, Doctor, would you agree with me when I say, listening to your responses and testing Dr. Schwer's post-mortem against the standards that he has set up in his own book, that in this particular case, he failed to adhere to his own standards?
I would agree completely.
Now, in the section of your report, which is under the general heading, Other Aspects of Witness Testimony, paragraph 67, you make the point that prior to 2006,
Yes.
forensic mortuaries were only run by the police. Yes, obviously the case back in 1969. What impact did that have, the fact that they were wholly under the control of the police, on the relationship between pathologists and police and the question of loyalties?
Well, I can speak on that because I was also a trainee and a junior doctor during that time. I can advise that being fully controlled by the police, the premises, the staff, the resources, including your typists, your transport, everything controlled by the police, it was very difficult to operate unhampered. Although if you threw your toys out of the cot, you would get what you want in a case like this. So it was very difficult to work with the police at that stage. It was one of the big reasons for the takeover by another ministry in 2006 because of the compromised situation, mainly because the too close relationship between the medical people, the district surgeons, far too close a relationship, and the police in investigating their rights and the atrocities and the abuses that occurred in the system. So, Lord, it's for this very kind of case, as the death of the Imam, that the management of the mortuaries was taken over by another ministry from the police.
Thank you. Doctor, the team representing the family is trying to make sense of what the late Imam Haron endured while in detention. And listening to your evidence today, we've heard from you about groupings of injuries in relation to both the location on the body as well as their ages.
Yes.
And if I heard you correctly, you distinguished between the subcutaneous injuries discovered on the upper body, mostly on the front,
Yes.
which in your view would have taken place potentially some months previously because the external injuries had healed.
Weeks or
Weeks or months. Thank you. Then there were the large and numerous yellow and green bruising, mostly on the legs, front and back. And then lastly, the smaller reddish bruising on the lower legs, the shins. And whereas the yellow-green bruising, you seem to accept to be between 7 to 10 days old, the red bruising, smaller red bruising, the fresher, around 2 to 3 days old. So bearing that in mind and contrasting that with the evidence gleaned from the first inquest, we've attempted to place the detention into various phases. And I just want to put these phases to you and see whether you would agree with them as being reasonably descriptive of what the Imam endured. So the first phase would be from the date of arrest, 28th May, through to the end of June, beginning of July. The evidence suggests that there was frequent interrogation. Indeed, Van Wyk talks about daily interrogation. But it's quite possible that any injuries endured at that time probably would have healed unless perhaps some of the subcutaneous injuries could be connected to that period. Then the next phase would be early July, which corresponds to the taking of the statement. So that's roughly the first, I believe, 11 days of July, I believe 2nd to the 11th of July. And around that time, we saw the evidence of complaints made by the Imam. And in your evidence, when dealing with the upper body injuries, you indicated that they could potentially be connected to what took place in early July. Moving to the next phase, and this is the phase from 11th of July all the way through to 18th of September. And in this phase, there isn't much information except for the complaint of rectal bleeding, I believe around the 14th of September. Then, of course, we have that crucial period in which the Imam was removed from Maitland and taken at least to Caledon, that's under undisclosed places, between the 17th and 19th of September. And of course, the police alleged the staircase fall on the night of the 19th. Then we have and of course, what took place in that period given the complaint of the Imam and being returned to Jamaica, and given the ages of the yellow and green bruises, that could potentially be connected to what happened between the 17th and 19th of September.
I would agree.
Because approximately a week later, the death takes place, and those are the estimations on those injuries.
Yeah.
And then lastly, the period 20th to the 27th, the date of death. In your table, you see out in detail complaints made and requests made by the Imam in that period. And then, of course, we have the red bruising on the lower shins,
Yeah.
which could only have taken place in itself.
Yes.
So that description of phases, in your view, does it reasonably describe or reflect what probably took place, given the medical evidence at your disposal?
Yes, I believe it does. I also believe I recognize these phases. I just want to add one thing that I think we must also bear in mind that the state of health of the Imam would have been much better in May and June, and he could have endured more than he was enduring, or he was able to endure in late September. So I believe that it's possible that we must bear in mind progressively worsening health status, and with a escalating degree of successive violence, it becomes a malignant issue, weakening and escalating of violence. It becomes worse.
Dr. Naidu, may I ask you to read your conclusions into the report, the chief inferences that you draw page 19 of your report, paragraph 71.
Yes, I read as follows. My chief inferences drawn from analysis are summarized below. Number one, the injuries were of moderately severe degree. Full stop. Number two, there was neglect of appropriate medical attention, which would have resulted in systemic complications of blunt tissue injury, soft tissue injury, in particular of the crush injury syndrome. Number three, the death was in all probability due to the combination of severe systemic physiological stresses resulting from the injuries with pre-existing coronary artery disease. Number four, the amount of force applied to the body to cause the injuries should be regarded as substantial. Number five, the injuries of the body do not correspond to the allegation of the fall, as was described. The injuries are characteristic of a sustained physical assault.
Thank you. Now, Dr. Naidu, my final question to you is, but for the assault and abuse that was subjected to Imam Haron during the period of his detention, would he have died at that time?
My belief, he would definitely have not have died at the time that he did it, because I believe he could have survived for an indefinite period, perhaps even years, if there was actually coronary artery disease, which I will say a lot of us will probably already have here at this existing moment in time, some degree of coronary artery disease. So, yes, I believe he would have survived, and possibly indefinitely.
Thank you, Doctor.
Thank you, Council.
You testified that it is law for the procedure that SAP 180 accompanies and what monitoring. Is that correct? Answer correct.
That's correct.
And in essence, that should be completed by the museum officer tasked with the matter, or alternatively with the person responsible for transportation of the body to the marshal.
Yes, the second option is always less preferred. We would prefer the investigating officer, but it's not restricted to that. Another policeman who's available can do the same.
And also, I understood from the record that between 2006, the usually was the unit of police services.
That's correct, yes.
And I also understood from the testimony that the SAP 180 would also have some characteristics of explanation to it, relation to the body, how it was found, and so on.
Yes, it's limited. It's limited maybe to the original SAP 180 was limited to maybe 5 to 10 lines, but the conscientious investigating officer would not only present himself at the autopsy and be present like he is supposed to do, but if in case he is not, he would arrange for an alternative representation but provide full details to the pathologist, especially in a detention, political detention case.
And if I am correct, that it is my understanding that from this inquest as you provided, there was none.
Correct.
Now, perhaps if I just want to read to you, and then maybe if you can offer an opinion, referring you to that was the exhibit B of the original inquest, and it is found as volume 1. The values of the NDAs have been let into record by the NDA. And this particular exhibit B of the original inquest supposes to be a position by one Petrus Erasmus, who at the time was a constable in rank and was stationed at the mortuary in Solbury.
Yes.
And it appears that he was then the forensic who then take the body deceased and transported it to the mortuary.
That's correct. I understand he picked the body at the scene.
At the scene, that's right.
And taken to the mortuary.
Yes. Now, where I just want to draw your attention in his affidavit, as I made reference to where it was found. It says on the second paragraph that of the Susan 21st September 1969 was at the Fund SA Police Varna at Tekhanet na Lakeland Police Station, Giham Fanekirche, Mandeke, and the Orca and the Constable Beggar, and the Assembly Lakeland. And then it goes on further to say that there's in fact a proviso that is noted there that you give a description of what he observed on the body. And in that paragraph, there is a line that is stretched two across.
I don't have a copy of that.
Perhaps from what
at least a translated version, or untranslated, translated. I only have one on my computer.
perhaps if we just maybe put this in simple terms, what I mean, there should have learned to give at least what is there from reference to the relation. together, Dr. Naidu?
Yes, I got it.
You've got it. And then you can confirm that actually it reads as that's the person that might have obtained the body of the deceased and transported it to mortuary surgery.
Yes.
So we already.
Yeah.
And I'm also correct to draw attention to the fact that where it directs to give an explanation of what the person getting the deceased body with the indication of any